Good afternoon, everyone, and welcome today to our webinar, which is going to speak and cover about patient and family engagement. And the specific topic today is how can hospitals promote patient and family engagement? I have with me five speakers, including myself, and we will be covering this session today in 1.5 hours. And on the screen, you can see my introduction. I am the founder of an organization called Patient Academy for Innovation and Research. And to give you a little background about this organization, this was started 3 years back with the aim of empowering patients in the Asia Pacific region to understand their health and be the owner of their own healthcare and be able to take decisions along with their healthcare providers. So I won't go much into the background about myself, but we work across the region, and patient safety is one of our flagship programs. Over the last 2 years, we have held a series of webinars on medication safety, have commemorated the World Patient Safety Day last year as well as the year before that. And we have plans for this year as well on September 17th, which is the World Patient Safety Day. Um, I will now briefly introduce all the speakers and then follow up with the agenda and the objectives for this webinar. And then we can have the presentations from the speakers followed by a Q&A session from our audience as well as from our panelists. So our first panelist today is Einstein, and he's a very passionate patient advocate and a board member of the Philippines Alliance of Patient Organizations from Manila. He's an innovation consultant and blockchain marketing consultant in Australia. He is also a certified innovation professional and a global innovation management from the Global Innovation Management Institute, Cambridge, Massachusetts, and has a Master's of Science in Innovation and Business, Asian Institute of Management. Welcome, Einstein. Our next panelist today is Dr. Netraj Gandhi. He is the chair of the Health Information Management System Society India Chapter Public Policy Committee and heads the APAC business for THP. He has a list of achievements to his credit, and he has worked with the Cleveland Clinic for the expansion plan in India. He's led the digital transformation for Faki Care in KSA and is digital visionary, orchestrating complex turnaround and cloud migration, cybersecurity, mobility solutions, and core HMIS enhancement. His expertise spans strategic finance, international collaborations, medical technology adoption, analytics, development, project management, and startup mentoring. And he's a key founding member of the prestigious H&N Reliance Foundation Hospital and has a unique educational journey from esteemed institutions and has transformative insights for healthcare industries. So welcome, Dr. Gandhi. Our next panelist is Professor Amrahi. He is the president Malaysian Pharmacist Society and has over 35 years at University Malaya Medical Center, Kuala Lumpur, Malaysia. He is a visionary pharmacist rising from pharmacist to deputy director at UMMC and has steered MPS as president with impactful leadership. He has, to his credit, innovation introduced during his presidency and has global collaborations and leadership beyond borders, guiding MPS through COVID-19 challenges, and his impact has been felt across pharmacy practice, advocacy, and mentorship. Welcome, Professor Amrahi. Our next panelist is Dr. J.S. Arora. He's an old friend of mine and has worked with me in India over the last few years on patient safety. He's a thalassemiologist with an MSc in hemoglobinopathies from University College London, serves as the General Secretary of the National Thalassemia Welfare Society and the Federation of Indian Thalassemics, President of Pahuja Trust for Blood Disorders, and holds membership in various ethics committees, including those at IIT Delhi, University College Medical Sciences, Chacha Nehru Bal Chikitshalaya, Government of Delhi, and several other institutes. He is also an active member of the State Blood Transfusion Council and is a founding member of the Indian Alliance of Patient Groups. Welcome, Dr. Arora. Our agenda today is to cover four main topics. How can patient and family engagement contribute to safer healthcare? And the presentation will be made by Einstein. Followed by how hospitals can help in formulating strategies for promoting patient and family engagement by Dr. Arora. And that will then be followed by patient-reported harm, where and how to report by Professor Amrahi. And last but not the least, digital health and patient safety in this ever-changing healthcare environment and global continuity of healthcare by Dr. Gandhi. We will then follow that up with a Q&A session, and we'll try and wrap it up with key action points. The objectives for today's webinar are five. One is to, of course, raise awareness among the patient safety and on patient safety amongst key stakeholders to help us to understand the role of hospitals in patient safety. And this is very important because one of the outcomes of the Global Patient Safety Action Plan 2021-2030 is to embed patients and patient advocates into hospital systems, whether at the board level or the governance level or at technical committee level. Also to strengthen awareness of the Global Patient Safety Action Plan, the strategic objective 4, which is the thematic area for this year's World Patient Safety Day, which says patient and family engagement with the tagline, elevate the voice of patients, and then engage and educate patients and families to become patient safety advocates and support the theme of WHO Patient Safety Day for 2023. Without much ado, I would like to invite Einstein to make his presentation. Thank you, and over to you, Einstein.
Hi, a pleasure and a pleasure to be here. And thank you very much, Dr. Ratna, and our speakers here. And I'm glad to be part of this celebration. For me, it's a celebration to be having a chance to voice out the needs of our patients. If Keshav will share my slides, I'll go through here quickly.
Yeah, sure.
Perfect. So for my speaking engagement, I'll try to be as much informal as possible. I want to get my message across, and I hope you'll be engaged with my presentation. All right, next slide, please. So yeah, thank you for the conversation introduction a while ago. So I'm proud to say that I've been to India and I love Taj Mahal. It's a very paint picture view. The moment you get the chance to see it, it looks unreal. It looks like a painting, but once you get close to it, it's actually real. So yeah, those are my affiliations. I'm very proud to say that I'm a very certified, a passionate innovator. Those you may see all of this affiliation, but it all boils down to being an innovator and an advocate. So I combine those two and come up with fruitful impact towards health. Next slide, please. So I'm from the Philippine Alliance of Patient Organizations. So what do we do? We are a unifying body with one voice that supports patient organizations. This organization is a member of our organization, so it's an umbrella of all of this organization, and it has different diseases, from cancer, from kidney, from rare disease, you name it. So our main goal is to be that one voice in the Philippines so that policymakers, hospitals, different stakeholders will have a chance to understand what are the needs of the patients. Next slide, please. And we focus on three main things. We focus on the respect for patient rights, our universal health coverage, and we, of course, the goal here is to have patient representation in health policy making, so that your activities is not just one-off, but have a sustainable health outcomes. Next slide, please. I always start my presentation with this slide. This came from Hunter. This is my definition of why. The definition of why is how you are able to engage in health. First, we define patients as individual patients. These are the people who just experience the disease and trying to recover. Patient carers are the ones taking care. These are the nurses. These are the family relatives who knows medical procedures and has experience taking care of people. Patient advocates is my why. This is my definition why am I here in the advocacy, because my father is a stage 4 laryngeal cancer survivor. He has no vocal cords and has experienced a life or death situation throughout the recovery procedure. And I am a patient advocate before, and now I have elevated myself. I have built my capacity to contribute in a much more sustainable manner. So that's why I became a patient organization representative. This patient organization representative is the collective voice of a disease area. So you understand what are the needs of a cancer survivor, and that's where I am positioned. In the much longer term, I wanted to be a patient expert. These patient experts are the ones situated in the academe most often, but I believe Dr. Ratna here has some experience in R&D and of course participating in regulatory affairs, representing the patients in the government. Next slide, please. So now, I'm not sure how you will be engaging with me, but put in the chat if you believe this statement. Or maybe our co-participants will have a chance to say if they believe this statement. The amount of misinformation on Facebook, especially during times of crisis, is staggering. Do you believe that? Um, if you think you believe that, yes, believe that statement. But please read the whole statement that this is not said by Benjamin Franklin. Benjamin Franklin is not alive when Facebook is here. So please be aware, and it's our duty as an individual to know the whole context of the picture. Even though the first part is correct, you must know, you must validate if it's truly correct. Next slide, please. I posted that slide because I believe in this post by Straight Times that misinformation is really the next third world war. We are receiving a lot of misinformed decisions by so-called influencers who has not validated themselves throughout experience, or who have no medical experience at all. So as a patient leader, as a patient advocate, we must validate all the information that we are getting. We must position ourselves to be the voice as the central information of correct and validated information, so that the people who propagate misinformation will not cause harm to other patients. Next slide, please. To further validate that, we are seeing the increase of different generations on who they most believe it. So, as a patient advocate, times are already changing. If you are not, if your organization is not being searched by Google or is not being positioned in a social media, you are already invalidating your value. You must create a social media presence. We must adapt to our current environment, because the Gen Z now believes a lot of information coming from Google rather than the ones in the professional arena. So let's position ourselves, be present in in online channels. Next slide, please. Highlighting there is the primary care. In the Philippines, we define primary care as a whole of society approach. So if you are an individual or a patient care or a patient organization representative in this spectrum, we believe that you have a position to play in the role of to contributing to better health outcomes. It may not be direct in a sustainable position in the government, but you can find a way to create a framework that you are best situated in. But ultimately, the last bullet here is empowering individuals, families, and communities to take charge of their own health. Meaning, They are empowered to create decisions by themselves, but they are guided by the whole spectrum, which is the primary healthcare whole of society approach. Next slide, please. You may have seen this slide. This is our main thrust, which is the WHO Global Patient Safety Action Plan. This patient and family, this emphasized that patient and family engagement is key. It is one of the foundations that you can see in the pillar. So in building a pyramid, one of the most important thing is the foundation. You can see here at the center of the pyramid is patient and family engagement. And I am very glad this has been emphasized by the WHO, and we have a specific strategic objective on a global level, and it is our role and responsibility to bring it our to the country level. Moving forward to the next slide. I'm also very glad that WHO not only specifies strategic objective, but they created a framework for action. And this framework for action is very customized to your organization. So if your organization is specializing in information or research, go pick one. You don't have to have all of the framework for action. You can just pick one and specialize from there, and you will be able to contribute to have better healthcare outcomes. I will not go through this. I think it's a good time for you to read this later on, and I think some of the speakers will be sharing this more. Next slide, please. In the Philippines, the culture for health is, I think you'll be relating with this one, is pretty much paternalistic. Even though I have a different opinion, I follow a different side of it. And the ones taking care of it is really my mother. Um, Oftentimes patients struggle to obtain information, and they just base it solely on their experience. It's a hit or miss in some of our traditional families in the Philippines, and we have a gap of information to bring it across to remote areas. In the Philippines, we are over 1,700 islands, so bringing across information, it's is quite hard. Even though digital is coming, we don't have full internet access to all regions. And I think that is one of the gaps that we are trying to address. Third is there's a lack of support for patients getting involved in decision making and policy making. Even though we're pushing, there is still not enough patient representation in the government. It's more of a protocol to invite a patient to hear their thoughts. It has to be mandated that you have to seek advice of a patient expert or a patient organization representative to convey the message across. Next slide, please. Keeping that in mind, our organization created a postgraduate certificate. This is one of our main thrusts, and we launched it this year, and we just finished the cohort last June. This short course postgraduate certificate is partnered with the Asian Institute of Management. The AIM College, the AIM Business School is built by founders of Harvard as well. So it is situated in Manila. So we designed a course that is complicated enough but basic enough to understand by patients. We focused on 5 modules, and these 5 modules is what we think are vital to having a patient leader being capacitated to make sustainable decision making. So driving healthcare leadership is very important. You must understand the landscape of where you at. Data analytics is very important because the government and all of the people believe on what is happening, and it is must be through data driven. Healthcare and patient care innovation, this is where I come in. I love innovation, I love tech innovation. We all have mobile phones, let's make use of it. Internet is readily available, let's make use of it. and especially the forthcoming of ChatGPT. Even though ChatGPT is reliable, we must still put practice critical thinking in just copy pasting all those what we hear from ChatGPT. Um, Four is a results-based impact monitoring. Monitoring is very important because this is where you get the evidence. This is where you get best practices and creating a model out of it. Module 5 is bridging leadership. This is where we co-create healthcare solutions. This is where you transform a patient advocate to becoming a patient organization leader. And this is where we have an action learning project. Next slide, please. The output of it is an action learning project. And this is what the overall themes that have come out with the objective of having a better health outcomes. I will not go through this, but the themes here is situated in a way that we are not all attacking in one entry point. We will be situated in attacking multiple entry points, making a bigger impact. Next slide, please. This is one of my last few slides, and I want to share this with you. This is how we envision contributing to having a better health outcomes. And specifically, we have a project for hospital approach. This is one of the ALP projects because um, we wanted our organization to be part of the board of each hospital here in the Philippines. We are partnered with the Philippine Hospitals Association, which is the largest organization of all hospitals, and they are a source of fund because they believe in the vision as well. But being partnered with the organization creates a bigger network for us. So contributing more to better health outcomes are the individual organization experience. I see, I told Dr. Rana this before, and in the innovation world, we call it pocket of innovations. This pocket of innovations are little sprouts of activities, which is very sustainable in the long run. If you are able to collect all those and create a meaningful objective and a sustainable strategy for it, you'll be able to achieve a better health outcome. And partnering with a corporation such as a hospital, they will be able to understand what you are doing, what is the impact, and what is the cost benefit to the patient and to the business. I hate to admit it, but hospital is still a business if you're engaging with the hospital. So if you do not understand what is the language of these businesses, you might be able to have that communication gap. Posted here in our challenges are the capacity building, the relationship building, and having that transparent communication with these stakeholders will help you develop um, a better situation for your organization. So this model is very much our work in progress model. We have seen successes in our postgraduate certificate. We are proud to say that we are engaging with the Philippine Health Insurance to have a sustainable relationship. We have been identified as the go-to patient organizations for any healthcare concerns, and we are also negotiating for building a funding network where we will be centralizing the funds to PAPO to fund minor activities of the organizations of our members. Next slide. So I like to end my presentation with a simple quote where education is not learning of facts, but training of the mind to think. Um, in a way, um you'll be able to just not get the information, but what you're going to do with that information is pretty vital. We call this in the innovation world learning how to learn. If you don't know how to learn properly, you will not be able to execute it properly. So next slide. I think that is my last slide. We believe in the statement, nothing about us is without us. So no healthcare policy should be decided without the full and direct participation of patients and members of the groups affected by that policy. It doesn't make sense if you're not part of it, but it's for you. So with that, thank you very much and pleasant afternoon for you, to you all.
Thank you, Einstein, and very nicely presented because we started with how can patient and family engagement contribute to safer healthcare, and you seem to have already traversed a long part of the journey. Especially through with the postgraduate certificate program that has already initiated a cohort that has created a few leaders who are now implementing independent projects, and also positioning your national organization as a go-to organization with your healthcare authorities, with your hospital association, as well as with the insurance agency. I think that's a dream for most country level coalitions, and you already have, positioned yourself at that level, and it'll be interesting to understand how you traverse that journey later in this webinar. So thank you very much for that presentation. And I would now like to invite Dr. Arora to speak about how hospitals can help in formulating strategies, which actually flows very well from how can patients contribute to how can now hospitals include patients into their strategies, and how can they promote, patient and family engagement. So over to you, Dr. Arora.
Thank you, Doctor. First of all, thank you for inviting me to this important webinar on the World Patient Safety Day to marker. And it was a good learning from Einstein as well. So as you know, the focus of the theme of this World Patient Safety Day is patient engagement. And you have restricted on the hospital formulating strategies for promoting patient family engagement. So I like to share my views on that. So you can see my slide. It's visible. Okay.
Yes, it's visible.
Yes. Okay. Why patient engagement? Why? See, the patients and their attendants see things that busy healthcare providers often do not. They offer the richest resources of information related to medical errors, as many of them have witnessed every detail of systems failures from the beginning till the end. And patients have much more to offer than mere reminders to health providers, and because they are the victims of the tragic medical errors. The voice of patients and families who have suffered preventable medical injury is a powerful motivational force for healthcare providers who wish first to do no harm. So patient and family engagement is not a separate initiative. It's a critical part of what the hospitals are already doing. They're not going to add anything extra. They have to just improve on that. So what are the benefits of patient and family engagement? They contribute through informed choices, safe medication use, infection control initiatives, observing care processes, reporting complications, and practicing self-management. All this translates into measurable improvement in quality and safety. Medical center implementing policy to promote patient-family engagement have seen 62% reduction in medical errors, 40% reduction in falls, and 50% decrease in length of stay. Research has shown that patient and family engagement consistently predicts hospital performance on an area of crucial business outcomes. It also decreases litigation and malpractice claims and leads to lower cost per case due to fewer complications and shorter length of stay. Engaged patients and families serve as an early warning system for potential bottlenecks in care of process. When they are disengaged, hospitals waste resources in the form of delays and higher call volume. They have to receive more calls from the patients and repeated patient education efforts. See, improved CAPS, that is Consumer Assessment Healthcare Provider System, hospital survey scores, and patient experience of care. See, reimbursement is tied to benchmark performance of CAPS hospital survey, and hospitals are rewarded or penalized based on their performance on specific measures. Hospitals that have implemented the strategies to improve patient engagement have seen subsequent improvement in patients' rating care. At Georgia Health Science Medical Center, they saw increase in patient satisfaction score from 10th centile to 95th percentile, which is very high. There's a positive effect on patient outcomes, specifically emotional health, symptoms resolution, functioning, pain control, physiological measures. Even when you see blood pressure, blood sugar, they also improve when you are engaging the patients. Reduction in rate of preventable readmissions. Cleveland Clinic increased its market share with additions in both new and returning patients after including patient and family in the patient-centered care. Griffin Hospital saw growth in both inpatient and outpatient volumes. Survey of more than 2,000 patients in which 41% indicated they would be willing to switch hospitals for a better patient experience. So you see, these are the examples of how patient involvement improves the hospital credibility. It also helps employees' satisfaction with their work, leading to higher level of attention and an improved ability to recruit quality talent. Another hospital, that is Bonson Methodist in Michigan, then led to a drastic increase in the average nurse turnover from 21% to 7%. They could retain more nurses, and hospital saved over 3 billion in 5 years. So what are the 4 steps that hospital will see to start the process of engagement? Step 1 is identify opportunities for patient and family engagement efforts. 2, get commitment and support of hospital leadership. 3, form a multidisciplinary team that include patients and families. 4, implement and evaluate the strategies. Let us come to step 1. First of all, assess hospitals' needs and capabilities. Identify ways in which you can engage patients and families to help achieve your hospital's short, mid, and long-term goals. Conduct an initial assessment of organization's patient and family engagement and patient and family-centered care policies. Review quality information and data related to core hospital processes. Get input from clinicians, hospital staff, patients, and families, and review policies related to visit and family presence during the hospital stay of the patients, indoor patients, you can say. So get commitment and support of hospital leadership, because board of directors play a critical role in setting the tone for the entire organization. Unless until you have got their support, you can't do anything. Senior leaders like CEO, CFO, CEO, CIO, they ensure that organizational transformations required for patient and family engagement efforts occur. So these all things happen only when they are involved. Clinical leaders assume responsibility for ongoing program, set expectations for superior performance, model behaviors, and mobilize improvement efforts. Other hospital leaders, such as unit managers, ensure that engagement efforts occur daily. It is not you just only do once a week or once a month. It should be involved daily. So how to bring senior leaders on board? Relate to achieve hospital goals. You must to tell them that it will achieve hospital goals outlined in a vision statement, and strategic plan. It will help in realize quantity and safety improvements, that is CAPS hospital service scores, improve staff satisfaction, improve financial performance to decrease litigation and malpractice claims and fewer complications, help differentiate hospital from others by establishing a brand identity around patient and family engagement. These things will help the senior leaders to be involved in the patient and family engagement. Step 3, see patient and family advisors. Patient family members are critical members of team. They should not be just the token members and should have just been on the board, that's all. They have the same voice and presence on the committee as hospital clinicians and staff. Make them sit on the multidisciplinary team as well. Some hospitals, they just involve, just keep on their record that they are on the board, but they don't involve them in the decision making. So if you have to look for who should be the patient advocates, look for the several patients or family members who have had recent care experiences at your hospital and who are interested in helping to make improvements. Hospital to be effective patient and family engagement involving hospital leadership is critical to promote and support the change. Hospitals may not need to be involved daily, but they should be engaged and they should be informed regularly on ongoing basis. Multidisciplinary team can help set time-specific goals, establish measurements of improvement, use a standardized process of implementation, measure progress towards goals, and provide timely feedback about that process. Develop a succinct explanation to senior leadership of what you want to do, why you want to do, and what resources you will need. Only then they will be involved. Reach out to hospital leaders via regular meetings and rounds with patients and families. Identify the overall scope and aims with senior leaders or multidisciplinary team. Recruit team members, including clinicians, staff champions, key hospital staff, patients and family advisors, and hospital leaders. Review collected data and information and prioritize areas for improvement. Finalize which strategies and which unit will be selected first. Because you are not going to do, as Einstein is telling, you are not going to do everything in a one. First, select which you want to do and how you want to do, step by step. And evaluation is must because it identifies potential data sources, collection analysis, assesses the effectiveness of interventions, whether we continue, expanded, or made permanent, which you can say where you want to be continued or where you want to be changed. It keeps key stakeholders apprised of progress related to patient and family engagement, keeps individuals engaged and enthusiastic. Because if you evaluate regularly, the people will be engaged and enthusiastic to know the results by demonstrating goals and objectives are being met. So strategies to engage patient and families, working with patient, families, and advisors. Hospital can work with patient and family members as organization level advisors by providing a mechanism for involving patients and family members in policy making, facility design, and the planning, delivery, and evaluation of the care. It helps improve communication between patients, family members, clinicians, and hospital staff, often from the point of admission, including giving patients a clear understanding of how to ask questions, who to go for information or help, and how to participate in the care. Working with patients and families at bedside. Nurses' bedside shift report supports the safe handoff of care between nurses by involving the patients and family in the change of shift report for nurses. Because we have seen many medical errors happening while shifting of the shifting stage of nurses or you can say clinicians. So this transition is not good. So again, we coming today, transition care from hospital to home as well, which is also very important. So ideal discharge planning helps reduce preventable readmissions by engaging patients and family members in the transition from hospital to home. So how to plan ideal discharge planning? Include patient and family as partners, discuss areas to prevent problems at home, educate the patient and family, access patient and family knowledge and understanding, listen and honor patient and family wishes. Here I can give you 3 examples. As you're you're discharging a diabetes patient, you have to teach him how to give insulin injections at home. Same way what we do in thalassemia, the patient has to take injection that's not ready regularly at home. So we teach them how to use pump, what is the dose, how much water will dissolve. So all these things should be given to the patient in hand, even in the not only orally, but also in the leaflet form, so that if at all patient forgets, they can review at home. So, sorry. Patients are more engaged in their own case, generally have better outcome. They, if they feel more involved in his health decision, if he will be more proactive with his health instead of reactive. They also want to access their information, because many times what we have seen, the hospitals are giving even this critical reports. Let's say, I like to share one example. If a patient was admitted in a prestigious hospital, he had a yellow urine. He was admitted under gastroenterologist for jaundice. Later, it turned out to be malaria, falciparum, and the patient was not transferred to the physician. Gastroenterologist was not looking at the malaria part. He was just treating as on the jaundice. Incidentally, the family was known to me, and when I went as a family member, then we transferred the patient to a different hospitals overnight, and patient could be saved. And I'm sure that at that time when I visited there, patient was already in the coma. So you see the patients are not being transferred from one specialty to other specialty. Had the family known that the patient has been diagnosed with malaria falciparum, the family would have convinced this consulting doctor to shift to a physician so that they can have the right treatment. So what are the ways to engage? So something I have already disclosed, that is patients as board members of organizations and government, appointing persons who identify as patients or patient advocates to governing body, establish a functional area within the organization whose role and accountability is to engage patients and families. Because unless until somebody is accountable, that they should be involved. So everyone say, okay, we have just given their name and they are not coming, all these things. So there's somebody in the hospital should be accountable that they are involved. Include patient advocate input into improvement committees and or root cause analysis. If anything mishappening occurs or any medication error happens, then they should be involved in analysis of the cause. The patient as partners as carers, the care partner or family member present and engaged for all conversation. They provide support and an extra set of eyes and ears because they know what is happening to their patient. Let the patient with the family at all times and least restrictions to visiting hours. This, if the patient carer or family members along with the patient, they will tell what has happened in between the times when the nurse or doctors were not there. So they can report easily to the consulting physician and the nurse what happened when they were not there. So it will help to reduce the medication error. So they inform treatment whether it is standard, inform them whether it is standard protocol or research procedure. Offer to see, contribute to medical records. If your patient cannot understand, let him ask the questions. Many times patient may not understand what is written on the reports. You can tell him what it does means. For example, in the diabetes, 7.1 as per A1C, patient may not be knowing. But you can tell the patient, yes, if this level is more than that, it is diabetic, it is pre-diabetic, and non-diabetic, like that. And always ask patients to come prepared with questions, medication list, other healthcare information, conditions, and medications he had in the past. Here, I like to give my personal experience as well. Whenever I ask a patient to come for me, I always ask them to bring at least one more member from their family. Don't come alone. Reason being, many times patient doesn't want to tell something which he is doing, say drinking, smoking, whatever maybe, or diabetic, not adhering to the diet. So the other member will tell. Secondly, patient will not understand whatever you have told him. He will forget 6 out of 10 you have told him during the clinic. So when 2 persons are there, at least every person will remember 5, 6 things, and they can discuss at home and review or call you back for if there is any confusion. So act like a teammate. Do not treat patient as an object. Involving carers as key partners. Carers have expert knowledge of the person being cared for and their condition, and also of the health and care system they use. Carers should be involved in designing services. Train carers for their caring roles. As I had told earlier, the carer should be informed what to do in which case, like the hypoglycemia. If the carer is aware of the condition, the hypoglycemia, sweating, weakness, all these things, then they will care. Otherwise, they say, okay, he will recover after just water and so on. So preparing for the engagement, educate, prepare.
Dr. Dr. Arora, can we close,
Just 2, 3, yes, very 2, 3 slides are there. Educate, prepare, and empower patients and family to engage effectively in their health and healthcare. So let me flip this slide. So it continues the engagement. It can be direct care. Patient receives information about diagnosis. Patients are asked about their preference of treatment and treatment decisions are made based on patient's preference, medical evidence, and clinical judgment. It is not left to patient alone because he is not aware of all the scientific information. So at organization level, organizations survey patients about their care, and hospital involves patient advisors for advisory council. Patients co-lead hospital safety and quality improvement committees, which is very important. And same thing for the policy making. And they should have equal representation of agency making that make decisions about how to allocate resources to health programs. See, and I'll again give just one example. What we have seen in our thalassemia, the more funds have been allocated for the, you can say, screening, but not for the treatment. So patients are, though who are already there, they are not getting adequate funds for the taking medicine. They are being misused for the just purchasing machines, etc. So the patient should be on the policy decision as well. So with patient engagement means improving the patient experience, including quality and satisfaction, improving population health, and reducing the per capita cost of the healthcare. So it is not the doctor should say they get to know us, but patient wants you should know me first. Thank you.
Thank you. Thank you, Dr. Arora. Very well described. However, your first slide said that the patients know more than the physicians because they have a lived experience and physicians are busy and they often miss something that the patients and caregivers know. So while we are aware that many hospitals do put in an extra effort to involve patients and caregivers, adverse events do happen, or medication errors do happen, or near misses do happen. And then, the patient or the caregiver doesn't know who to report to or how to report or what to do if something happens, whether within the hospital premises or outside the hospital premises. So our next speaker is Professor Amrahi, and he has a lot of experience on patient-reported harm, especially coming from a country like Malaysia, which is very advanced in its pharmacovigilance systems. So I would like to invite him to speak about how Malaysia has advanced its, harm reporting and how they capture data to be able to improve not only their healthcare systems but also their policies. So over to you, Professor Amrahi.
Thank you, Dr. Anna. Can I have my slides, please? Okay, put on show first. All right, thank you very much. All right, good morning, good afternoon, and good evening to all attendees in this webinar. My sincere thanks to the organizer for again inviting me to share my thoughts on this given topic. My name is Amrahi Buang, the current president of the Malaysian Pharmacy Society. I'll be sharing on my previous experiences in UC Malaya Medical Center, Kuala Lumpur, as well as in facilities outside of the Ministry of Health and also private hospital in Malaysia. Due to my background, I will focus on medication harm to patient. Next slide, please. If we look into this slide, we are talking about medication misadventure. Actually, it focuses on two main areas. One is medication errors. The other one is adverse drug events. And as you know, the medication errors are all actually preventable events. And for adverse drug reactions is non-preventable events. But the most important thing is the fact that the harm is what is actually we are interested. So this is actually to describe, whether the errors will actually be harmful to patient or not. Next. So you can see we also cover the near miss, and I mentioned earlier the error can happen, but there's no harm. There's one more where the actual error and there's some. This where we really need to focus because this is what the subject we are talking today. Next slide, please. All right, if you talk about the medication use process, it's quite simple. All right, it began with the prescribing process, and then we talk about the dispensing process, the administration process and monitoring. And so this is basically the medication use process, and any error can actually happen along this process. Next slide, please. And somehow or other, when you talk about in the real world happening in a daily situation, whereby somehow or other thing can happen. It can happen at the level of the physician or the doctors, because these are actually the level of defense to prevent actual error. Yeah, it can happen, at the pharmacist level, when actually they when they dispense the medicine or when they give the medicine, and of course in the ward, even the nurse can even miss the thing. But I think the most important thing is the fact that if the patient is actually have high literacy on what is going on, and also they are aware about their medicines, I think we actually can prevent this. So this is just one of many things that can happen. Next. Well, I think I'm sure you guys are very clear about why the what you call the medication safety is very important. At least one death occurs per day. So that's why I'm trying to say that this is a very important, because it's happening daily, right? And according to this, in 2009, 1.3 million people are injured each year due to medication error. So this is actually a serious thing. Next. Right, and you can see why medication safety is important, because it really have largely the impact on the patient. Talking about the health status of the patient, the magnitude of the overdose, and also the damage as a result of omission, as an example. Yeah, and also on the other side, when you talk about the financial implication, so we are talking about prolonged hospital stays, increased healthcare expenditures, estimated to cost billions of dollars annually, and additional medical management, and of course, when you talk about error and so on and so forth, medical legal cases and so on and so forth, then you talk about legal fees and out-of-court settlement. So it is really a big issue throughout the world. Next slide, please. Well, so this is the one that is going to answer regarding the topic. Yeah. So when we talk about the reporting system, all right. So these are a few steps that we can do. Number one, if something happened, okay, the patient can actually notify the healthcare provider. Okay, so how do you actually, who to inform? All right, they can inform the doctor, the nurse, the pharmacist, where actually, to obtain the supply. Because as what mentioned by Dr. Arora, when you talk about the whole thing in term of medication, the what you call the patient have to really collaborate. All right, but as I mentioned earlier, okay, if for example they want to report, okay, they can report to this the healthcare providers. How do they report other than the one when I mentioned, when they are warded in the hospital, if the thing happen, it's okay, means it's still under the healthcare provider. But if for example, if the patient is discharged or for outpatient, then in fact they can actually report, or if they are at home, they actually can even do a phone call. Yeah. And what happened is that what will happen is that once this report came in, all right, of course the usual thing will happen. All right, we are talking about the medication error or the adverse drug reaction report. So of course we have our internal investigation, and we have a root cause analysis, and definitely the organization will actually go back, or give the feedback letter to the complainant. Next slide, please. So the next one is basically to notify the health facility, whether it's in hospital or whoever actually become the provider. And this is very important for the fact that this is something that the patient can do, all right. And usually, is in form of talking to the customer service of the facilities, which probably they have their public relation, and of course they have also official feedback and complaint through online form. So this is something that that patient will be able to do it. And again, as with the earlier slide, there will be internal investigation, RCA being done, and feedback letter to the complaint. This is really something that is that can be done. Next slide, please. All right. I want to bring this because of the fact that if we look into the whole picture, even though we are actually focusing on the on the hospital, yeah. But once the patient is outside, okay, discharged and so on and so forth, and all these misadventures happen, yeah. So I think there's another avenue where actually the patient can within the community, right, actually go to the nearest pharmacy, community pharmacy, where you can actually report, okay, if something happened, or you can even call them. And now with the with telepharmacy and WhatsApp and so on and so forth, is even easier now, yeah. And of course, the community pharmacists will place a report in the National Medication Error Reporting System. And of course, the pharmacists can advise on the next step. And also, they may help to convey the report to the relevant health facility that supply the medication. This is, for example, once they reach home, they got the wrong drug, or for example, they got somebody else medication and so on. So all this can be done this way. Next slide, please. All right. So this is a bigger picture. All right. When because I'm talking from the point of the Ministry of Health in Malaysia, and also the for the university hospitals. Okay, they can report to this ministry. This is basically what's happening in Malaysia, where we have the national reporting system. So for MOH, so they have their own website and also apps, to do it. And for the ministry that's in charge of the university hospital, they also can use that link that's mentioned in this slide. Then the authority, both MOH and also the Ministry of Higher Education, will request investigation to be done by the relevant health facility and the facility to provide feedback to the complainant. So you can see that in Malaysia, we are able to do it, at any part of the country, 24/7. Next. So I just want to share with you regarding our national medication error reporting system. So MERS background, yeah. So began in 2009, all right, and they developed the MERS online, and then they have what you call in 2013, they improve, they have they put it online and so on and so forth. So currently now, all right, they are able to be what they are in now. All right, so you can see it started in 2009 and now it's 2023. So you can see the experience that we have with MERS. Yeah, so this is something that they improve all over these years. But I think the most important thing is that what we are trying to say is that medication safety is everyone's responsibility. Next. So you can see the objective of the MERS system. All right, once we get the information, of the ME, we can actually analyze the medication error report, and we also can learn what happened, because the whole idea is actually to find out why the error happened, and to minimize such errors. And at the end is actually to improve patient safety. And you can see on the right side where all those outcome analysis we can actually gather from MERS. All right, next slide, please. All right, so you can see that this is the whole thing when you look into the actual what you call system, and every healthcare professional. I mean, when I say everyone can report, meaning that when you talk, if any healthcare professional, either in government or private sectors, they can access this through that website. I'm sure you all also can search for this, and there's already a proper guideline of how to do it step by step. Next. All right, and you can see that when we talk about the harm and how we actually measure the outcome. Yeah, of course, we also cover near misses as well as actual errors. All right, and then from there, we categorize into all those. And so what we're interested is the one in yellow. Okay, where requires treatment and intervention which cause temporary harm, or initial prolonged hospitalization also cause temporary harm because of what has happened. And then we also look into permanent harm, okay, and then near death event as well as death. So we are able to categorize. Next. So you can see from 2012 to 2022, you can see, there's so many things that we're able to do now. But I'm sure, honestly, definitely there will be still underreporting. Of course, it's been increasing, but it's still underreporting, because if we look into things that's happening, is really underreporting. So we hope that all healthcare professionals can play their part and report to the national medication error reporting system. Next. And you can see even we compare between the actual errors as well as the near miss. So once you have a system, of course you can play with the data, and you can see and see what can be done. Next. Okay, this is another one what we have in Malaysia, where we call it as conserve. This is actually under our National Pharmaceutical Regulatory Agency, or NPRA, under the Ministry of Health. Yeah, this is actually the consumer reporting of side effects to medicine or vaccines. So this is something that really the population of Malaysia, right, actually can report directly to MPRA through this concept, right? And from there we will do the follow up, right? So this is already established in Malaysia. Next. So you can see, even because for this, right, we actually have if you go into the website, they will explain detail of how to do it, and then be able to have follow up on this. All right, and for that is quite simple. So you can see how effective is this during the pandemic COVID-19, especially when you talk about the EFI. Yeah, so we have this system because, as you know, when you talk about harm as far as EFIs is concerned, it's really have to be reported. After that, then, to go to the special committee, whether it's MedReg or whether for the vaccine safety committee, and then to see whether, whatever it is, at the end of the day, the government promised some compensation, So we have to really do it and be fair to the patient. Next. And of course, they can do it either through online, or they can actually download and even print out. Yeah, and all this to make it easy. And as you know, it's very clear. It's reported there. Everything remain confidential. Okay, so the most important is that, you know, this is something that that is what I would say, patient friendly lah, and person friendly. Yeah, in Malaysia. Next. Yeah, I think that's my sharing about the reporting system. I hope that it benefits the attendees. Thank you very much.
Thank you, sir. Thank you for highlighting how you are capturing medication errors through your online platform, medication errors reporting system, as well as your consumer, feedback on vaccines as well as medications. I had a couple of questions, but I'll come back to them later. But what is more important is that you have an established system for people who are reporting to, say, a clinic or a facility or a hospital. But during the pandemic, we have seen that healthcare has moved out of the four walls of the hospital with telemedicine, telehealth, and remote access taking over, and also the setting up of a lot of standalone units or clinics, especially for, say, dialysis or for infusions or for home ICUs, etc. So our next speaker will be speaking about digital health and patient safety, and whether digital health has improved access but compromised on patient safety or enhanced patient safety. So it's my pleasure to invite Dr. Gandhi to speak about digital health and patient safety. Over to you, Dr. Gandhi.
Thank you so much, first of all, for giving me the opportunity to speak here. And it's a bit difficult to follow Professor Amrai, given the fact that he educated through the presentation and finally brought a smile on our faces also with the word cloud towards the end. So I'll just try and, wrap it up as soon as possible in 10 minutes, because we need to give some good time for question and answers. Yeah, the next slide, please, Kesha. Yeah, so what has digital health done for patient safety? If I were to look at it, you know, first is it's enhanced patient engagement. The number of apps, the websites, all of that has come in, and as people have gotten used to the retail marketplace online, patient engagement has also increased. Everyone is talking about a digital twin, digital front door, so all of that is wonderful things. Second is healthcare is getting efficiently analyzed. Whatever the private hospitals are providing, everyone has a data visualization solution, a BI tool that helps them. Does it improve the care of patients? I think that's debatable. Some of it is debatable because I think technology also needs to be accompanied with great training. If people who are using technology are not trained appropriately, they can enter multiple types of data which may be accurate, inaccurate, and that impacts the care of patients. So I think while digital is great, training is one of the most important parts, and telementoring has been seen, especially Project Echo or similar initiatives. They've managed to train a lot of people, and that does improve the care of patients. But I think accompanied with training, it does improve care of patients. Timely assistance, the kind of alarms you get right nowadays, the notifications, everything is available by the bedside, on tablets, on their computers, for nurses as well as doctors. So that has really improved efficiency. I can vouch for one of the Indian healthcare chains where they were able to reduce their discharge time by about 50%, because everyone is getting notifications. The pharmacist gets a notification, the nurse gets a notification to educate people, and all of that. Human errors get reduced because the notification tells you exactly what to do, how to do it. There's better ROI on technology. People are not just spending for information but insights. Preventive care, if I'm a diabetic today, there are enough apps that are available that will educate me when to take my medication, what kind of diet to follow, how do I manage my exercise, when do I go for a checkup, and monitor myself. I think that's really good. Remote patient monitoring, reducing the workload on hospitals. Annually there are about 450 million hospitalizations, and the longer you stay in a hospital, the fatigue associated with it, plus the number of interactions you have, that also increases the chances of risk, as well as errors in patient safety, because there's only a finite number of nurses and doctors you have, and they need a lot of support. So the quicker you can have non-acute patients or chronic care patients taking care of themselves, I think that helps a lot. That supported with remote care monitoring, I think that's the way forward, where hospitals are taking care of acute cases, while chronic patients learn to manage themselves, they get educated better, and through the power of technology, you start taking care of 100 patients instead of one by educating them more. Now, the last point that you mentioned, Dr. Ratna, whether digital is doing more harm or helping, I think that is associated with data privacy, sanctity, and security, all 3 points. Now, privacy, yes, it is improved. Instead of everyone peeping through a patient record, digital can limit access to that patient record. You can, in a way, turn off the identification parameters of the patient even when you hand over the data for research. So that's great. Security, if people invest in security, I was consulting for one of the largest chains of hospitals across Middle East, and one of the problems was security. And if not taken care of, it leads to a lot of unlimited access to hackers to data. But if that can be taken care of, it's frameworks like NIST are available, which can make life very easy for people. It's a hard compliance, but once you get it right, I think that gives a good amount of security. Blockchain needs to be used, so that even when the data is transmitted over multiple mobile applications and other things, you are in control of what data is getting transmitted. And finally, the sanctity. As I've said, if the data does not have sanctity, it's of no use. So the harm majorly gets done because people don't maintain sanctity. You're recording a verbal order, somebody says something, somebody writes something, and that's where generally you drop the ball. So I think these are the 3 or 4 things. The best thing that digital has done is giving access to real time healthcare information, whether it is a doctor, whether it is patient, family members. The kind of access you get today, it takes care of the information asymmetry a lot, and that's where digital is important. Can I have the next slide, please? Yeah, and what uh, following Dr. Amrahi, what kind of strategy or safety improvement plans can be there to reduce these medication errors that happen? Minimize clutters, verify orders, use barcodes, involve the patients. All 4 are possible digitally. Can I declutter my pharmacy? Yes. Can I have multiple sub stores dispensing those same medications, thereby reduce waiting times and errors both? Yes. Can I have robots in the pharmacy? Absolutely yes. They dispense only a finite number of medications. The barcodes can be used to verify the medications as well as prescriptions both. The order verification as well as digital signatures can be used so that your prescription is a valid prescription. And finally, can we involve patients? Absolutely yes. If I give a patient access on the mobile phone for different medications that have been prescribed, and a link is provided for the drug monograph, that can clearly highlight what kind of adverse reactions to expect. There can be a set of instructions about what do you do in emergencies, the do's and don'ts of the prescription. So that's one thing about medication errors. The second kind of errors that you get, can I have the next slide, please? Can I have the next slide, please? Yeah, something that at designed for a hospital. How do you measure your quality and patient safety? Just a snapshot of the card. Transforming patient centered healthcare. In terms of infection control, how are you measuring your hand hygiene overall compliance? How is the transfer getting documented? How is medication reconciliation getting documented? And one of the most important thing, false prevention and pressure ulcer prevention. The moment you describe a patient or tag a patient in the system as a high risk patient and classify that this is how the patient needs to be transported, that reduces the fall risk by a lot, also takes care of the mobility needs of the patient. The third thing it can impact is the pressure ulcer prevention, which is the most I would say the most difficult thing to handle right now. Whenever you transfer a patient, they are bedridden for a long time, the kind of bed you use, the kind of mobility they need to have, is the nutritional assessment for such patients done? All of this can be taken care of digitally if you start empowering the family of the patient in terms of managing the weight of the patient, managing nutrition of the patient, also understanding the mobility needs from the family itself. So whenever a nurse or a hospital personnel is not there, you can quickly involve the family, understand a bit more about the patient, and take care of their needs. And finally, all of this ties back to a patient experience survey and a net promoter score, so that at the other end, what did the patient feel about any such checklist being followed, all the measures that were taken care of, handling the needs. So that's how I believe digital works. And finally, one last slide. Can you just go to the next slide, please? Yeah, this is a performance dashboard that I believe every hospital should have. How many times did you lose time in providing a medication, taking care of patient safety? How many medically treated patients, that's where you lose time? How many injuries happened? How many people versus incident? That kind of scorecard. What was the root cause analysis, from to date? What was the root cause, an external situation like a fire, accident, something like that? Or was it just an adverse event? Was it an event related to verbal orders or misinformation to the patient? If you can capture that in a scorecard, I think the CEOs, as well as the people who are working very closely in terms of the leadership team, the head of pharmacy, head of nursing, all of them can get together and start working on minimizing these risks by analyzing root causes. So some of these things is what I believe digital brings in. I know we are out of time, so I'm just going to stop here and happy to take the questions now.
Thank you, Dr. Gandhi. And maybe I will start the questions with you because you made a presentation on a dream hospital that has this kind of a system. But we all know that not all hospitals would invest to have this kind of alert mechanism or a reporting mechanism. And not
Mhm.
all hospitals would be measuring themselves on a scorecard to see how well they are performing on reducing harm. And given that we have a diversity of patients as well, because I think a lot of what you said that the patients could do themselves would be a measure of health literacy and whether they have access to mobile phones that can use those apps. So, given this background, how can hospitals convert themselves into better health systems that are actually reducing harm, even if they do not have the resources to invest into these kind of systems?
So I think, Dr. Ratna, that's a very good question. And over time, the way I've seen it is, irrespective of the kind of economic health of a patient, I think most of them are now turning towards apps like WhatsApp or the patient app themselves to educate. Now, WhatsApp is a very controversial thing, especially when you start sharing some confidential information or patient related information. But as an information tool, when you get into my hospital, I'm using a channel just to give you information, general information, deliver healthcare literacy. If you're a diabetic patient, these are the 4 or 5 standard precautions. There I'm not mentioning the patient name, but I'm just mentioning the precautions or do's or don'ts within the hospital. I think that becomes a very useful tool for hospitals that are not willing to spend too much in technology. When you can spend a bit more on technology, you start streamlining these things a bit more, so that within the hospital you start putting in screens, you start having some sort of signboards which can keep educating people, or health bulletins educating people about how investing their time, the time of the family on patient safety, has helped the hospital reduce such errors, has helped patients to be taken care of better. I think that's the second stage. And the third stage is where you start empowering your own employees with certain tablets or other devices, where you help the technology take care of repetitive information. I think that's one of the biggest problems. We all of us travel by flights, and one of the things that at least I have started becoming a bit ignorant about is whenever somebody starts saying those safety instructions, and that it has been done so many times. Now I don't need to pay attention to it. And I was traveling to Africa, and in Jambo Jet, they have a beautiful system where the screen pops up, and on the screen they are demonstrating through animations what you do. That despite having heard those safety instructions multiple times, sometimes technology can just bring those things alive and engage you for 30 seconds, which are probably very important to engage. And that's exactly what we need to translate into patient safety also. I think that's how we can use digital in stage based
Thank you,
medicine.
Dr. Gandhi. That's really very informative, and that brings me to the next question to Professor Amrahi, because while where you in countries where you have mixed health systems and the private sector would invest in these kind of systems to reduce their costs and litigations, etc. A lot of times it is government led. And government and public hospitals need to invest in these kind of systems, and uptake of technology in government is usually a little slower than in the private sector because of obvious reasons. So how can governments be motivated to invest in these kind of systems, and what could be the, I know both of you presented a lot of statistics, both Dr. Gandhi on the benefits of investing in these kind of systems, as well as yourself in terms of reducing harm. But what could be the message that patients and patient advocates and families can take to the government so that they are motivated to invest in these kind of systems?
I think this is a very good question. So I want to share with you the latest that we have in terms of the government policy or of the gender policy of the Malaysian government, new government. Yeah. Okay. The parliament actually have passed what we call as the health white paper. It is actually a framework of what we want to do for the next 15 years. It was actually tabled in parliament, and everybody agreed. So if even we have a change of government, we still have a framework. With this, one of the thing is actually digitalization. All right. So they want to go into that. Right. So I think it's very important that the government of the day, or something that you want to give to the population, you must have a proper framework. All right. I agree that there are pockets of all this, even in government and also in private. And I also agree with Dr. Nitraj. The best would be, like in my experience, where we have a proper accreditation process. Right, be it whether it's local or international, is up to you. But when you have this accreditation process, then you have to do it, because we are talking about two things: quality and also safety, and all this will come into picture. So I think it's very important, even though you may be lacking in terms of technology, but if you have a good quality management system, all right, and then you put the safety inside that system, it will eventually work. Even though, say I started it, probably 2009 I've started all this. Okay, but even earlier, when we don't have this, we are able to do it because we instill the quality culture inside the hospital. So I think that one is very important, because management is all about quality management. So if you do that, then we're talking about accountability. You know how to manage your resources, and you know how to go from step one to wherever, and you can, like, quality is all about continuous improvement. So you improve step by step, But I think, as what Dr. Nitsa said, now the whole world is changing already, right? The whole world is
Yes, very
changing, and the pandemic has teach us, even in the Malaysian what you call experience, where we have an app that during the pandemic, that the Ministry of Health actually have the app, which is almost the whole population have access to that app. So we already have that app that we can actually communicate, and that's where we can put all things now. It's now the problem now is, after the pandemic, what are we going to do with that app? But as I say, I think since the technology is there, we actually can use this to connect and so on. But I think the word that I want to say is, actually we have to increase health literacy. We have to increase the literacy of medicine, especially for chronic patient. And most important thing is the fact that, if everything want to work, it has to be make it simple, doable. And I can see, when you talk from what we share with the other speakers, I think our biggest challenge is communication.
Yes, I
Communication is
completely agree.
communication is the one is really the main source of all this misadventure, especially for even not only medication but also other harm lah. So keep
Thank you.
going.
Thank you. I think thank Yeah, transparency and communication, and how do you give the message, that is extremely important. And that brings me to my next question to Dr. Arora. You mentioned a beautiful step-by-step process of how hospitals can enhance patient and family engagement. However, a lot of it depends on how well trained the healthcare professional are on safety aspects. And as you already said, doctors and healthcare professionals are extremely busy, especially in this part of the world where footfalls in hospitals is very high. Given this, and the fact that Einstein mentioned that even though patients want to be engaged, sometimes they do not have the means or the resources to be able to educate themselves. So can hospitals actually train patients as well as their doctors and healthcare systems? And if that system were to be brought into force, what could be some of the steps to do that?
I think you said rightly. See, even still today, we don't see anything happening in India, at least I can say. But yes, certainly in some good private hospitals, they have started making hospital safety committees. And if they become active, and as I have told you, that there should be some focal point. One person should be accountable for the making the hospital committees active and implementing the decisions of the board. Then it can happen. But still, I can say that it is. I have talked to so many hospitals in government as well as private. When I talk to them, they say we have a hospital safety committee, but when we ask them who are there and what is the meetings happening over there, they don't have any answers. And that is even the government hospitals or be it the private hospitals. When I ask them to just activate, no, no, see, there is one thing is there, that is because of their fear of blame game, because they
Yeah.
fear if at all anything happens wrong and the patients report the medication error or medical errors, then they be blame on the doctors. So that is the one thing. I think the best solution is there should be some anonymous reporting.
Yeah.
There should be no blame game, and the doctor should be ensured, or whatever doctor, nurse, whoever may be, pharmacist, they should ensure whatever you report, it will not be going to take any action unless until it is really big, you can say, negligence on your part. Otherwise, there should not be any action. That is the only way when we can promote it. So, and the patients are ready to report. But the problem with the patient is patients want to report directly, means pinpointing the actual person to whom, from where they have got the this error done, or you can say hospital. They want to name the hospital, instance, doctor. And unless until they also report anonymous and the authorities also take anonymous reporting, it's not going to happen. So we should encourage, first of all, anonymous reporting from the patient as well as a decision by the hospital authority. Then it can happen.
Thank you. And that brings me very nicely to Einstein, because he mentioned that he has a certificate course where he's creating a cohort of patient leaders who actually understand how to communicate any errors and engage with hospitals and healthcare systems. So Philippines has been, and Papo have been very successful in starting this course, but not all countries have this opportunity of tying up with academia to create a course. So if other countries have to follow your example and create, say, a country level network of patient safety experts, how would they do it? And how can you encourage patients and patient organizations to move forward so that some of the problems that Dr. Arora highlighted don't happen, and there is a more transparent and cohesive way of reporting, patient harm?
Exactly, exactly. I like to make my first point because change in every aspect is hard. I took my master's degree at the same school, which is the Asian Institute of Management, and I noticed a change in my conversation, a change in my understanding of the frameworks, a change on how to make an impact. And I realized that why not create something that is dedicated for patients? One of the biggest barrier that we saw is the language barrier. It's not in terms of language, in terms of English or what, but it's at the level of understanding how a patient leader can be transformed, that he will be capacitated to communicate what is needed to be communicated. Um, if we if our model can be followed perhaps to other countries, the biggest barrier you will be having is to understand the level of knowledge of your existing patient leaders. If you have a good gauge of what those are, they might be very experts in their prior years, but if you have that equilibrium, that level of knowledge to communicate, you will be have a greater impact. um Bridging to that point, we have like 20% having a hard time to finish the course itself actually. So our strategy was to level off in a group of people where you divide them. Korea, I must say, has already started the conversation in this. I've shared them the model. They are very interested and they are looking forward to pilot it sometimes next year. And hopefully that conversation will move forward to other countries such as Malaysia, who is very progressive in patient care, and perhaps India to have a bigger impact in terms of quantity. And looking forward to working with you guys.
Thank you, Einstein. And we are a minute over our allocated time. But I have one question from the audience, and perhaps either Dr. Arora or Professor Rahi can take this. Because I think the question relates to including patients and family members on hospital boards or other regulatory mechanisms, and I think it also reflects on what you said, Dr. Arora, about blaming people and holding people responsible at an individual level instead of bringing it to the institutional level. So one of the fears that hospitals have is that if you bring patients too close to the decision-making authorities, then there could be maybe some blame on the hospital. How can that be mitigated and how can that be reduced? You already said it has to be anonymous, but sometimes there has to be systems where data can be masked so that individual hospitals or doctors are not named, yet you can identify the institution where the harm happened so that there is analysis. So perhaps a 1 minute thought from both of you.
Uh, I'll just like to add, as Professor Bai said, that communication is the best thing. See, if you communicate with your patient, with transparently, with clearly, because this I have seen happening in my practice as well. The more you communicate, the more you tell them it's transparent, and the patient is ready to cooperate. It will be, you can say, not. It will not, even if the error happens, he is not going to blame you. But only thing is, it should be the transparent, and communication should be in a polite way. If you say, okay, we don't want to listen, you don't understand, your knowledge is not so, you are not a medical person. If you say like this, naturally it is going to be into litigation and you will have a problem.
Thank you. And Professor Amrahi, any thoughts from your
Yeah,
side?
I think in terms of anonymous, I think of course if we have a system where you can, you can have that, then it's fine. But also you can do it, especially when you go for accreditation of hospital. Yeah, actually there's a lot of things in place. Number one, we talk about clinical governance. Okay, then we talk about patient safety committee, and then under the patient safety committee, we have the medication safety committee and others and so on and so forth. So if all these are in place, yeah, so we can actually improve. As I say, it's improve. It's not about blaming people and so on and so forth. Of course, if something happen and we feel that it can be a potential medical legal case, then we have a different channel. The whole idea of medication safety, all right, is medication error, etc., is actually not to find fault. We want to see what actually happened, why the error happened. That's all. We are not blaming anybody. So these are the things that I think most important thing, we also can be patient, but I think the word is, if you have good communication, and then you build trust. That is the most
Thank you.
important thing, because if we don't build trust, then it's very difficult. Because as I say, with what Einstein, what I mentioned earlier about the infodemic, So I think this is something, as I say, we really need to educate our patient, the health literacy, and also the medicines literacy. At the end of the day, we do not want to cause any harm. But I think the most important thing at the end of the day, if for example you talk about patient on long-term medication, I think the issue is medication adherence, all right, and it's very important, because at the end of the day, we want to have the outcome, and that is very, very important. And it's important to have a team approach. A team approach means the patient at the center of our care, be it the doctor, be it the nurses, pharmacist, or any allied health. So it's a teamwork. It's really a teamwork. So you need to develop that. You cannot put everything to the doctors. It's wrong. Because they have their own work, we have our own work, and so on and so forth. And things are getting, different, because of the fact that the patient are now have a lot of information. So we really have to be clear. And as like what we talk about the digital space now, all right, of course, with telemedicine and telepharmacy and so on and so forth. So I think it's important for us healthcare professionals to respect each other. It's not about fault finding. What we are saying is that if anything happen, is actually we make sure that we have to be frank with the patient, unless it's a potential medical legal.
Thank you. You used a lot of very important words: trust, communication, respect for each other, and working together as a team, where the patient is at the center of healthcare. With that, I'd like to thank all our panelists for taking the time out on a Saturday. Thank you so much. We had such a rich discussion. I will reach out to you for further inputs on a paper that we want to put out as a result of today's discussion. We have a series of events that are marked for September. Please do watch out our social media handles, because we will be posting them there. Again, thank you all for joining us today. It was a pleasure hearing you, and thank you very much once again. Have a nice weekend. Thank you, everyone.
Thank you.
Thank you,
Thank
everyone.
you.
Thank you,
Pleasure.
everyone.
Thank you. Thank you,
Have
Eins.
a nice
Thank you.
day.
Thank you,
Yeah.
Dr. Ratna.
Thank you.
Thank
Thank you.